Hi. In our last video, we started to review the anatomy of the respiratory system. We covered the nasal cavity in a great detail and saw why it has certain adaptations to serve its specific functions. On this video, we will return to this diagram, and as you can see, we already covered two first areas that we set out to study: the nose and the nasal cavity, and the paranasal sinuses. Now, following the path of the air into the body, we are ready to shift our focus on the next part, pharynx. So let's discuss it a little bit. So pharynx is this muscular tube that runs posterior to the nasal cavity and all the way down to the start of larynx, roughly at the level of the vertebra C6. Its function is, I would say, to connect the nasal cavity and oral cavity to the larynx and esophagus. And an interesting thing to note here is that, as I mentioned, it is a muscular tube. This muscle is actually skeletal muscle. You might remember a review of the muscle tissue types from our earlier intro classes. If not, check out the link that I have added to the end of this video. Pharynx is divided in three parts that we will have a look of. And let's start with nasopharynx. Nasopharynx is located posterior to the nasal cavity and runs from there to the level of soft palate and uvula. These close separating the nasopharynx during swallowing. So anyone who has ever had a soda or milk climbing up there, is this mechanism has temporarily failed, knows why these get separated during swallowing. Another thing to notice is that within this area we have our pharyngeal tonsils and also the opening of an auditory tube, which I mentioned in the last video. Let's have a look at the oropharynx. This space runs posterior to the oral cavity from the level of soft palate to the epiglottis. Palatine tonsils are located here as well as the lingual tonsils. And finally, we have our laryngo-pharynx. This is posterior to the upright epiglottis and extends to the larynx, where it continues as an esophagus. So those are our three regions of pharynx. And the next one that we will have a look of is going to be our larynx. This is sometimes referred in layman's terms as our voice box, but it does much more. It runs from 3rd to 6th cervical vertebra, attaching superiorly to the hyoid bone. It also opens posteriorly into laryngopharynx and anteriorly is continuous with the trachea. And when you think of the larynx, probably the easiest way to think about it is the 9 cartilages that make up it. And again, we have talked previously about hyaline cartilage. If you have forgotten that, you can find a link to that video at the end of this one. Please note that the larynx is made of a combination of muscles, elastic connective tissue, and cartilages. We will focus on the last of these. So let's have a look at these cartilage parts that make up the larynx. So what we see here is a view from the anterior side on the left side of the screen and a sagittal section on the right side of the screen. And we will go through all the 9 cartilages that make up the larynx. Let's start with the thyroid cartilage. There is only one of these, and this cartilage contains a part that is commonly known as Adam's apple. The proper anatomical term for this is the laryngeal prominence. And you might remember that it is typically more prominent in men. And thyroid gland, which we talked about at the start of this course, is located at this level too. So this can be a good anatomical landmark for locating it. Next, Let's shift our focus to the cricoid cartilage. It is a ring-shaped structure, in fact, the only fully closed ring in the larynx. And it forms the most inferior part of the larynx. Trachea begins from here. And again, on some individuals, it is possible to feel it if you want a surface anatomy landmark. Next, we will look at the epiglottis. And again, as with the previous ones, there is only one of these. And the function of this flap-like structure is to close and seal off the respiratory pathway when one swallows. At all other times, it is open. This is important because ensuring constantly clear airway is our priority. Here I have an interesting figure for you. It is an epiglottis that is unusually tall one. It extends higher up superiorly than usual and could be seen from the mouth. Let's go through rest of the cartilage parts that make up larynx. There are two arytenoids, one on each side. They are located enclosed inside the thyroid cartilage, so only visible on this cross-sectional view that we have. So let's describe them a little. They are triangular cartilage structures, and the reason why they are so important for us is that muscles control their movement, and as they move, they manipulate the tension within the vocal cords. I have highlighted them on green on this diagram. Now, let's look at the corniculates. And again, two of those, both on top of each arytenoid. So you can consider them as these tiny tips on top of them. And finally, I want us to look at the cuneiforms. These are actually located within the mucous membrane lining, so not visible normally. That's it. Those were our parts of the larynx. But we should also talk a little bit about the function of the larynx. Well, the first and most obvious one is that it provides the airway for the air to pass along to and from the trachea. Then note that it is a structure that has an important role in routing the air and food into correct paths, either towards esophagus or trachea. This is important. And finally, this is where the voice production takes place. I earlier mentioned the vocal cords and arytenoids playing a role in controlling how tight they are. Let's have a look further on the vocal cords at this point. So vocal cords are located deep to the laryngeal mucosa, attaching to the arytenoid cartilages, which we just saw as we reviewed the parts of the thyroid cartilage. What is interesting is that these vocal cords appear white because elastic fibers that they are made of do not have blood vessels in them, so hence the color. And here, on this view acquired by a technique called laryngoscopy, we can actually see these white structures made of elastic fiber, as we just noted. And there is another term that I want to highlight here. Glottis refers to this space that is opening between the vocal cords. Some call it rima glottis too, especially on the old continent where I was trained. So, we manipulate the glottis to alter the sound generated by a vibrating mass of air passing through the vocal cords. So there are two sets of vocal cords that I want us to talk about. More superiorly, something that we call as false vocal cords. This is because they are not really involved with vocal production. And then we have more inferiorly the true vocal cords. It is the edges of these that vibrate as airstream passes through, producing the voice. Do notice, however, that the voice is manipulated also further higher up at the mouth. And just as a side tangent to this, if you have never heard about this, there is an instrument called Didgeridoo which originated from Australia. I used to live there. And how you play this instrument is that you manipulate the opening of your glottis, in fact, restricting the opening of glottis. And with trained vocal tract muscles, you can generate this very distinctive sound. You can check it out, for example, on YouTube. And this brings us to talk about trachectomy. This is an incision in the windpipe to relieve an obstruction. And this diagram shows that the positioning of this incision is very important. Hence, I wanted to bring it up at this point. And now we are ready to start talking about the trachea, so our windpipe, as sometimes called in a layman's terms. Let's have a look at that. It connects the larynx to the lungs. Average adult trachea is about 2.5 centimeters in diameter and between 12 and 13 centimeters in length. As a structure, it is very flexible, with the only complete ring being at the most superior part, the cricoid cartilage. Remember it from our earlier discussion. All others are C-shaped cartilage rings, and this would be a good time to consider why would this be the case. Well, there is actually a fairly logical explanation. Of course, these cartilages are there to strengthen the structure, keeping the airway open, but they are not complete rings for a very good reason. Let's have a look. So let's imagine that we have here a diagram of an individual at the level of the trachea, looking to the left, and we look down from the top. Notice that the trachea with its C-shaped cartilage rings is more anterior, and posteriorly there is oesophagus. So in case there is something large that needs to pass down the oesophagus, it can extend a little to the space normally held by trachea. Makes sense, doesn't it? I also want to mention that where the trachea ends at the level of mediastinum, it divides into two primary bronchi. And this point, where it divides, is an important one for clinical use. It is called carina. And for example, when you put a camera down someone's windpipe, you can see this point as an important landmark. And there is one more important thing I want to talk about. The wall of the trachea is covered with these hair-like structures known as cilia. They play an important role sweeping any impurities away from there towards the throat. Another clinically relevant point that we should talk about is the angle at which the primary bronchi enter the lungs after hilum. And we know that the angle is typically steeper for the right primary bronchi, and therefore it is the right lung where most foreign objects normally end up to. And I guess that there is one more important term that I want to mention here. So let's go back to this figure, and you see the green arrows pointing to the site where the primary bronchi enters the lungs. Well, this spot is called hilum. And of course, we will notice that as we continue down the respiratory tree, there are more and more branches that it divides to. In fact, 23 times. And each of these has a name based on the size of the branch in relation to the whole. So we have primary bronchi, secondary bronchi, segmental or tertiary bronchi, bronchioles, and eventually terminal bronchioles. And that concludes our discussion of the trachea and its branches. Now, let's move on and finish this video by looking at the lungs in a little bit more detail. So, the lungs take up the entire thoracic cavity, with the exception of the mediastinum. Also note that they start high up. The apex of the lungs, this is the most superior tip, is located deep to the clavicle. And they run all the way to the diaphragm, where the inferior surface of the lungs rest. This is known as the base of the lungs. Note how far the lungs continue at the sides too, where the diaphragm attaches. This continues laterally more inferiorly than people typically think. We have already earlier discussed about the hilum. This was on the mediastinal surface, so space between the lungs. And hilum is an area where the bronchi, as well as blood vessels, lymphatic vessels, and nerves enter and exit to the lungs. And I will leave the rest for you to review independently. Another thing that I do want to discuss with you is the lobes and major fissures that make up the right and the left lung. To start with, I want to draw your attention to the fact that the left lung is much smaller in size. This is because we have the heart in the mediastinum and it is located slightly left from the midline. So it takes some space from the left lung. And actually this indentation of the heart in the left lung's shape is known as the cardiac notch. Now, I want us to review the lobes on both left and right side. And remember, when using these terms, left and right, we always talk as referring to the patient's right and left. That's just a reminder. So what we have here is that on the right side, remember the right lung was bigger, we have 3 lobes. While on the left smaller lung, we have only 2. It was smaller after all. And these are called, on the right, from top to bottom, superior, middle, and inferior lobes. On the left, superior and inferior lobes. And another important term is fissure. Remember from our discussion of the surface anatomy of the brain and surface anatomy of the heart, a fissure was some kind of depression, a line that runs on a surface of a structure. So on the lungs, we have 2 fissures on the right lung. Horizontal fissure separates superior and middle lobes of the right lung, and oblique fissure separates middle and inferior lobes. On the left side, since we only have 2 lobes, we have only 1 fissure. This is the oblique fissure, and it separates obviously the superior and inferior lobes. So we should feel pretty comfortable with these terms. Now, let's have a closer look at the surface of the lungs. And what I have here is a diagrammatic representation of an enlarged area. And as you can see, there are actually 2 layers around the lung and a space in between them. And the innermost layer is known as the visceral pleura, while the outer layer is known as the parietal pleura. And what is worth noticing is that there is a space between the 2 and it is filled with fluid. Why would there be this space enclosed by 2 pleura and fluid in it surrounding the lungs? Well, this fluid helps to lubricate the sliding of these 2 layers against each other. It also cushions and finally helps to generate a negative pressure that causes the lungs to expand. Now, let's return back to this slide and notice that our bronchial tree wall structure changes throughout its length. So, while we move further down the respiratory tree, we will notice that the wall structure changes. Initially higher up, there is more cartilage, and as we move further down the tree, the amount of cartilage decreases and the amount of smooth muscle increases. And the very last thing that we will talk about on this video is at the very end of the bronchial tree. So what we notice is that as we move down the bronchial tree and smaller structures, at the very end we have something called alveolar sacs. These are made of clusters of alveoli. And it is at this level where the gas exchange happens, and they make the bulk of the lung volume too. And a final point that I want to make is that these clusters of alveoli have a very rich blood supply directly next to them. This capillary network around them and the very thin wall thickness of an alveoli facilitate optimal exchange of gases. So that's it for this video. We have covered a lot, and I feel that this is a good place for us to take a break here. In the next video, we will start putting some physiology into this discussion of ours about the respiratory system. Until then, take care.